Okay, let's go ahead and get started. Thank you, everyone. I'll go ahead and open the Central Oregon Health Council meeting. I want to thank the CAC members and CAC board for having us together today and talking about our strengths and how our communication loop and how we're going to be working together. And I feel a renewed sense of alignment and excited for what's in front of us. We even have some side bets about whether we're going to achieve the things that we agreed upon. And
it'll be well worth the money to lose. If you guys make it work, it'll be worth the money to lose.
Who doesn't love a side bet? So, and joining us, I know we have a few people that are joining us by Zoom. Do we have, so we do have a quorum?
Yes.
Okay,
yes.
We're good to go. Okay, wonderful. So let's go ahead with introductions. Emily, do you want to kick us off? We'll go around the room and then we'll land on virtual.
Fabulous. Yep. Good afternoon, everyone. Emily Solomon, St. Charles.
Hi, Dan Stevens, Pacific Source.
Brett Porterfield, Chair of the Community Advisory Council.
Megan Hayes was at Community Health.
Listen to Summit and now Village.
Bundy Sheets County Commissioner filling in for Commissioner Dare today, and Commissioner Chang is the alternate, but he's not available either, so I'm here today.
Glad you're here.
Paul Andrews, High Desert VSD, welcome.
Linda Johnson, Community Rural University.
Perfect. Oh, that's all. Tammy Bainey, CYC and Chair of the Board.
Carmen Madrid, Executive Director.
Okay.
Miguel Angel Rada, Project Manager.
Wonderful.
Kelly Adams, Council Admin. Nicola Arsenault, Program Manager, Health Council. Neil Smith, Central Oregon Health Council.
Gwen?
Okay, Gwen Jones, Central Oregon Health Council, Program Manager. Tricia Wilder, she, her, Pacific Source. Kat Mastrangelo, Volunteers and Medicine.
Mike Shercoff, President General Group.
Heather Kaiser, Public Health Director, Sheets County. Hi everyone, Katie Plum, I'm the Health and Human Services Director in this county.
Carol Moses, Health Council Admin. Elizabeth Schmidt, Vice Chair of the TAC.
Hi, Stacey Strong, I'm the Overdose Prevention Coordinator for Cook County and also
Excellent. Okay, and on the screen, let's go with Dustin first.
Everyone, Dustin Zimmerman, Oregon Health Authority.
Excellent. Leslie.
Hi, Leslie Newcomer, Senior Director of Medicaid Governance at Pacific Source.
Okay. Jeff.
Hello, Jeff Davis, CCO, Medicaid Medical Director, Central Oregon.
Wonderful. Erin.
Erin Fair Taylor with Pacific Source.
And my high school buddy, Megan.
Hi, Megan Boyle, Director of Operations at COPA.
Lovely. Gary, Dr. Allen.
Yes, good afternoon. Gary Allen, Vice President Clinical Services, Advantage Dental. I'm in a hotel with funky background music and limited bandwidth, so I'll be on mute and off camera most of the time.
Okay, wonderful. If you see something fun, go ahead and go on camera. All right. So the first thing I want to say, and this is a carryover from the meeting that we just had, when we come around this table and we sit in the room together for these meetings, I want to just draw our attention to the fact that we're here actually, yes, we might represent certain organizations, but we're actually on a journey together, and that's the one of the Health Council. And so I just want to remind us all that the hat in which we wear when we sit around this table in particular is one of helping to create a healthier Central Oregon, and that is the collective impact of all of us as individuals from the organizations that we represent, but we actually represent the board as we sit here together as well. So a distinction that I know is one that we all recognize, but just want to ground us in that as we start today's meeting. So the first thing that we have on the agenda is we have the consent agenda, and it's my understanding that we're going to be pulling the minutes from the consent agenda and bring those back next month. Is there anything else on the consent agenda that we would like to, there are some edits to the minutes. That's it. Okay, so anything else that, if not, I would welcome a motion to approve the consent agenda as amended. Oh, I thought we had the, didn't we have your report in? No. Just in written, oh, I thought we accepted it. Okay, my bad. Well, then we have no action to take. Okay, so moving on like a herd of turtles, let's go to the governor's request. And this was before us at our last meeting, and we had a conversation about the governor's request on our youth behavioral health investment and a collective call to action. So, would you like to take the reins?
Yes, thank you.
Okay.
So after our board meeting, I had a meeting with Pacific Source with Erin Fair-Taylor, and I'll refer you to page 7 of your board packet, which summarizes all of what I'm about to share with you. Is Pacific Source approached the council and approached all of the CCOs, and I was in that meeting with Erin Fair-Taylor and Tricia Wilder, and what happened was that there is a governor's request to support the statewide expansion of behavioral health youth services. And of course, many of you that are in this space medically know that our youth are suffering across the state. For residential facilities, we are actually having to send some of our kiddos out of state, some of them not so young. And so there is this sort of emergent ask from the governor. And that emergent ask is across the CCOs, and within Pacific Source, they're looking at shared savings. As you know, in our JMA contract, we're set up pretty well because we've already identified in our joint management agreement that 50% of our shared savings would already be invested into behavioral health. And so with that, if you look at the second, I think the third bullet point, our estimated 2022 shared savings is estimated to be $12.4 million. Half of that would be the $6.2 million allocated for behavioral health. The ask from the governor is $1.4 million from our Central Oregon region, and the ask is based on membership. So a lot of the CCOs got together and basically said, okay, how are we going to allocate these dollars or put into the pool the $25 million ask across the state? Our contribution would be $1.4 million from shared savings. So one of the things that we did in order to have some leadership around it is we got the behavioral health leadership group, and it was just fortunate that we were meeting that Monday after I talked to Tricia and Erin, and that meeting was actually going to meet because it was an action item from this last board meeting to talk about our shared savings process, since we don't have a formal process on how to distribute shared savings behavioral health funds. So that group met on August 21st, and there were 2 agenda items, one being developing a process for shared savings, and the second, we appended the agenda for the governor's ask. The group got together, they understood that this 1.4 million ask from our CCO is something that we should invest in, and they went ahead and approved it. And so that is a recommendation they're bringing up here to the board, that we would contribute into this governor's ask. So prior to that, we did not know what the recommended investments would be as of September 1st, and you could see how quickly this is going. And so, really we were trying to get a vote, a virtual vote, but really based on the way our procedures are, the vote needs to come up at a live board meeting. So since then, September 1st, these are the 4 investments that the CCOs are recommending to the governor. We still haven't received a response whether that has been accepted or not, but this is where these recommendations are headed. So some of the questions, just for your information, is that a lot of folks were saying, well, where are the investments headed? Because we want investments east of the Cascades. We need access just as well. And the locations for these, the closest would be the Gorge and Lincoln, according to what my understanding is here. So currently this is where it's at. I know that the recommendation is to move forward with the $1.4 million investment from our shared savings that we're expected to receive this year.
Questions?
So just for specificity, where are the 4 items of the investment?
It's on page 7, so the investments A, B, C, and D. Community Counseling Solutions Project located in Eastern Oregon. Looking Glass Project, 2.3 million in Lane County. Trillium Family Service, which is the Perry Center project in Portland, and Adapt Project located in Douglas County. And just know that there has been a lot of advocacy for this region. However, what the governor was looking at was shovel-ready projects. And these were projects that were really just ready to go and just needed the funding. So
is it fair to say we invested $1.4 million to get $2 million back for Eastern?
you know, that was kind of, I knew you were gonna ask that, Justin. I think the question is also, what does the contract look like, you know, with these Eastern Oregon regions? And that's still soon to be said. That's the piece, that the operational piece is still being worked out. It is a question though to say, if we are investing, you know, what number of beds could potentially be reserved for us. So all of that is still open for discussion.
Is there an allocation of those beds? Is it John Day? Is it like?
Not at this time.
Okay.
But I think that discussion is happening, so it's not off the table.
So the ask for us is to put in 1.4 million.
From 25 million from the rest of the CCOs.
And the Eastern Oregon CCO would they contribute to?
They would put in their pro rata share, and so it was basically a pro rata across every CCO to reach 25 million with the stipulation of shovel ready, with the stipulation of the focus being on youth behavioral health. And as you can see, the pressure point that the collective group decided to try to really address is psych residential treatment beds, which even though they're geographically located in only certain pockets, they serve a statewide purpose. I don't know the answer about the ability to kind of reserve beds based on the investment, not knowing enough about that system of care in terms of how that could roll. But I don't think that was the intent here. I would say that.
You don't think
The intent is to increase availability and be able to leverage that.
Trying to be more specific though, are we trying to say the central hub of 12 beds, or are we trying to say go to where the people are, so there'll be something for, like John Day, there'll be something for these outer communities that have to ship everything in, or we don't know?
What we do know is that the expanded capacity would allow us, like in Central Oregon, these kiddos could just held at the and or even in some cases go out of the area because we don't have capacity either in Eastern Oregon or over in the valley.
I was just trying to understand, if you put 12 more in our area and we fill them, how does it help? It doesn't help with John Day, it doesn't help Eastern Oregon.
It's still, I mean, you move the capacity, but when it's full, right?
Okay.
Yeah.
So
But 12 is a big
the
increase.
answer is we don't know.
The answer is, I think the answer to that specific question is we don't know that easily.
Linda.
I read the proposal, it's really with all the different parts, it was really well written. The 1.4 million says it doesn't need to meet HRS guidelines. Why is that important to us if we're giving 1.4 million to the government?
Normally, any shared savings dollars, including CBI, all of our dollars are basically under compliance of HRS regulations.
Right.
And so there's a piece of it that was an ask, and we said, well, if we're going to give this $1.4 million, does it need to meet HRS guidelines? And the answer was no, so that we can still be in compliance.
So if they hadn't said no, and we gave the money to the governor and the governor spent them in a different way, it wasn't compliant with HRS, we could be held liable.
Right.
Got it.
So just making sure that piece was covered.
Okay. Thank you.
Right, in other words, it checks that same box that we always wanna check when we're allocating our own local investments, like we are working on right now for the dollars that we're trying to get out the door from the 2021. Checks that.
And I think that having had family members, one particular state placed in the system recently, it's usually based on acuity, not necessarily on location. So while we may added capacity means added capacity for every child, and youth, but it may not mean added capacity to our own kids here. Even if we had our own facility here in the area, it may not be that they might have their own.
That's what I was asking.
Yes, so, yeah. But is there a need for added capacity in the state? Absolutely. Is there a need for us to have a place instead of the emergency department where our youth wait? Yes. So I think this is just one part of a larger question. And so one of the things that we had talked about early on was, this is great if we want to contribute to stand up added capacity in the state, but is there a phase 2 of this maybe for additional capacity, because we are still not going to be scratching the surface of the need? Was there any, I know that we had a conversation with the governor about that, this would be a sort of, there'd be another iteration, but is that something that was in the conversations too?
We haven't heard that yet, and we
Okay.
don't know what else, because, once you stand up infrastructure, you still need program services to support it. So,
Right.
I mean, that's just kind of what we're thinking. I think this is a first attempt to say this is a need and it's a collective impact solution for the whole state. So that's really the way that we're kind of looking at it and framing it and supporting it.
You said one more time, did you say the funding associated with this is a bill, but the
Expansion.
programmatic staffing and the margin to hire people, that's not in this?
I believe it's part of it, but if there's more wraparound services needed around it.
Then that's, okay, cool, thank you.
Aaron, just real quick, if we can dial a friend, Aaron or Tricia, I don't know if you heard the question. My sense in reading the CCO proposal back to the governor is that it's more than just brick and mortar. The 25 million are more than just brick and mortar. It's to support the overall programmatic piece. Correct, Aaron?
It's a combination, but there was an expectation that once these programs were up and running, that they would be able to bill for their services and would be sustainable from that perspective.
Running 12, you're gonna run 12 psychiatric beds for 1.4 million.
I'm not.
Fair enough.
Other questions or additional information that we need?
Tammy, I think you planted probably a good seed idea for the process that is to come in the coming months with the remainder of the 2022 PH designated shared savings, right? And so what is it that this either potentially creates a springboard for, or says we still haven't solved here locally that we could potentially address with that remaining allocation? So I like where your head's at.
Well, I can't imagine that the best cost in return would be that we have individuals in the emergency department for weeks on end. I can't imagine that that's the most cost-effective way and the most humane way for us to be caring for our kids. So it's probably worth a broader conversation about how we invest.
Yeah.
So.
And I would speak to, years ago, we did try psychiatric res in Central Oregon for about 2 or 3 years. It was poor timing and didn't last more than a few years. It was truly implicated at that time, yep. And obviously since then, we send our kids out for psych res. That is what has been true for us apart from that 3-year experiment. I like the idea that we do have day treatment in Central Oregon. And we have need for more services.
Linda operated Trillium.
Yep.
So,
Opened it up, closed it down.
it was working it out, but it took it out.
With education.
Go ahead.
Just when I do the math on the allocation of the number of beds and the people and that concept, like these things work well on scale, but do not work well small. Like, so if you did rent children, it works well on scale. So whomever is the recipient currently of those kids, the money might be better served making that much bigger than. I know that's not the same thing as keeping them in the community. There's a very, very small margin on anything in this world. So
There can be a benefit to having youth out of community too for run risk and other.
just trying to say what 1.4 million does in this space in an established facility with established hiring and staffing lines is a lot different than what it does come out of the garage.
Yeah, absolutely.
Quality of outcomes.
It's significantly different.
Are you
So
looking for your
other,
action?
sure, yes, please.
Approval of our portion of the statewide expansion of behavioral health youth services as presented.
Second.
Okay, further discussion?
Can you clarify, that means we're voting to do this without those questions answered?
We are voting to do this because we have a short turnaround time to the governor. So we're either, this is the letting the good enough not, or the perfect not getting away with the good enough.
So this is trying something.
This is trying.
You can call your vote.
Okay, this is trying. Yes.
That's good.
Okay, all right. Okay, all those in favor of trying something?
Very good, I said.
Okay, all right. And anyone opposed? Okay,
I'm
I'm
gonna
going,
abstain just because I'm not a regular
Okay,
member of this
thank
board.
you. I'm gonna turn the reins over to Linda. Commissioner DeBonne and I are going to go honor a person that recently is passed on, and so I'd like to hand the reins to you, and that's the last voting item that we have today. So thank you. And thank you, everyone. That was a great meeting.
Commissioner Bonner, so you and Tammy going to the same place?
Stephanie, I'm outside.
Stay
And
for
I'm
the
sorry,
second
Linda,
part
if,
if you can, because it's discussion on the second part of the investment for shared
Yes.
savings.
I would love to, but I'm sorry, I do
Okay.
have a few items
Okay.
back. So.
I'm gonna join that.
Okay, video. Okay. Okay, thank you.
Nobody on this side table is leaving.
We'll be here.
You guys get bonus points for here.
I didn't see you last time.
So, the second piece of this, unfortunately, Rick Trelevin and Janice are both on vacation, and so I'm just gonna go ahead and present, the follow-up action item from our last board meeting. Our last board meeting, we talked about, a process for our behavioral health shared savings dollars. And currently, we've done really about 2 iterations of it. The first time, there was a small group that decided on 4 investments. And last year, we've done some creative things that we're trying, including a lot of the behavioral health group, substance use, and housing grouped together, knowing that those investments would affect behavioral health. So those investments are moving along. And this year, after we support the governor's request of $1.4 million, we will have a balance of $4.1 million. And so we really wanted to have a transparent process in making sure that we had one for these shared savings investments. So if you look on page 12, behavioral health leaders met, and it was Rick and Shannon Brister, Daniel Brown, Janice Garceau, Holly Harris, myself, and Rick Trelevin and Tricia Wilder. So we met, and the recommendations that came out of the group were very high-level recommendations on the bottom of page 12. And the process recommendation is, first of all, identifying behavioral health leadership. Who are the leaders that can actually help make these decisions? Is it just that group that met? Or do we also, again, involve CAC, maybe a member from Operations Council, maybe a member from our behavioral health work group? So those are things that we need to put some more detail around. But it's first to identify who that leadership is, identify emerging topics and initiatives supported by data. So, one of the things that we heard last time was the fentanyl crisis. What data do we have to continue to support that? Should that be one of the pieces that we decide to do? Identifying initiatives, not organizations. Traditionally, what we've done is when there's dollars that are available to the community, we put them out as grants as opposed to creating organizations and creating collective impact together to work on 1 or 2 projects, for example. Providing 2-year funding at minimum because we want to invest and see some outcomes, some long-term outcomes and impacts. Investments have to and must meet our HRS guidelines, and reporting must follow in line with our current grant process. So it doesn't have to be a grant, but we have to make sure that we can measure it and we can also take a look at what the outcomes are afterwards. So those are pretty much the high level pieces that the group decided on. I guess I'd like to open it up for discussion or any other thoughts or feedback that I could bring back to the group. We'd like to make a final recommendation by next month, primarily because shared savings will be available and we'll need to start the process. So that's all the fun stuff we get to do.
Just a clarification as far as kind of how the board packet's organized, if I could, because it may create some confusion. So with what Carmen is referencing on page 11 and 12 is the process that this work group is gonna help inform about how to do this set of investments for the next go round. But then starting on page 13, it goes back to the topic of the governor's proposal, and then those following pages are some more detail on that. I just didn't want people to conflate those two things based on how it's organized. And that's not a criticism, it was just like we went to this and then I think we went back to the other topic, and so if there was any confusion, just wanted to allay that. Does that make sense? Does that?
No, that's fine. I think we
12
just
through-
took advantage of that behavioral health group coming together and we said, hey, we're gonna talk about the governor's request to get their approval. That originally wasn't on their agenda.
Oh, that was from some of the minutes of there, okay.
Right.
So as I recall,
Two different
at
topics.
last month's meeting, we asked for this group to identify what's the ongoing process of how we'll decide, make decisions around the behavioral health shared savings. We also asked about for an emergent issue, what process would we use, and is there a recommendation in here for that? Or is that something that will come back next month?
I think that emergent issue topic was really a larger discussion with the board because this one was focused specifically on the behavioral health shared savings process. And then within that, we talked about, well, what are the emergent issues within behavioral health? And then that's when some of the fentanyl pieces came across. And so we haven't gotten to that piece yet to identify the emerging topics within behavioral health. But I do think there's a larger umbrella of addressing emerging topics. It came up in CAC today, right? Like,
But specifically around, for the behavioral health piece, is there a different process for an emergent issue or will it be the same process we use, the same group and the same process?
Yeah, I think that's a good question and we need to outline what that looks like, so.
Other questions or thoughts?
Carmen, did I hear you say there's an interest in perhaps kind of goes back to what Justin was saying about scale and how far the money goes to perhaps fewer initiatives, more dollars per initiative. Was that a theme that came out of this conversation? Is that a consideration in terms of having more impact on fewer things than less impact on more things?
Right. Yes, that actually has been a theme with our shared savings dollars. Our first investment back in, I wanna say it was in 2020, we're only with 4 organizations. And then last year, what we proposed were 3 work groups coming up with three broad initiatives. And so those were invested $500,000 each. So yes, that's correct. Like we want more dollars, fewer projects with large impact. Is I think where we're headed.
I appreciate the update and I like the process recommendation and the thoughtfulness.
We were reiterating what Linda asked in terms of the process. Is the idea that this would come back to us to ultimately approve? Would it stay, would that decision making stay with this group? What is the thinking there?
I think what's happened in the past is that recommendations come up to the board, but all of the details have been already kind of sussed out with this leadership group. And again, it's still identifying who is that leadership group. And I think that's the feedback that we're also kind of leaning on. Is it just this group from the minutes that stays at that leadership group, or do we have an opportunity to have more inclusion a seat with CAC. I mean, without making it like 40 people, right? But just having other voices and potentially consumer advocates that are impacted by these crises, so.
My question came in part from, historically, we gave, when we had a bunch of work groups, they each got a chunk of money, they decided how to spend it. There was a period of time where the more expensive stuff came to this table, and that was approved, and as we have changed, I guess I'm not clear if the intention is with 3 or 4 a year at the most. Would those always come to us as the board to ultimately say, yes, that is what we want to spend the money on?
Specifically just for our shared savings dollars, our behavioral health shared savings dollars. The rest of the RIP funding is actually allocated for those 6 work groups. However, the investments do still have to line up with the goals of RIP, our regional health improvement plan. So.
Okay, thanks.
Other questions or thoughts?
Will we hear, one more, will we hear back on who was identified as the leadership team and I suppose that'll all come back together with the funding requests, the details of the process?
I think so, and I think the question here is, do you have any recommendations on what a leadership team could look like? Do we want a member of CAC, 1 seat for CAC, 1 seat from Operations Council? Operations Council are folks that are actually on the ground doing the work. Do we want, we have seats for public health already, public health and behavioral health. Do we want a seat from a behavioral health group member?
Or behavioral health advocates, maybe, for example.
So
who currently is on the group by position?
By default, because of what was recommended, is in front of the minutes here. So right now we have Shannon, Danielle Brown from Pacific Source, both of them. Janice with Deschutes County Health Services, Holly Harris, who's the Deschutes County Behavioral Health Director, myself, Camille takes our notes for us, Rick Trelevin, and Trisha Wilder. And Rick represents Crook and Jefferson County with regards to behavioral health.
So the recommendations or thoughts about who additional leadership positions might be?
I see it mentioned in the conversation, Molly West Darling, the St. Charles Behavioral Health Director, who also works really closely with Deschutes County and the provision of mental health services. That would be a good addition.
Okay.
Just want to share, I'm no longer sitting in on this decision. It only set in on the first meeting process.
Okay. Thanks.
Guidelines.
Yeah.
I would be available if there's any questions.
What would be the role of a CAC member in that group? What would be the role? What kind of?
I think it's understanding the issues that are happening and the role. I can see a consumer representative who may have family members who have been affected by behavioral health or all of the things that are happening right now, would have a voice at the table from lived experience potentially. That's my thought around it. Could be completely different. But just to be more inclusive of all of our committees and work groups as well.
I like the idea, I just don't know if there's anybody on the CAC that fits that. Who we can invite.
I'm sorry.
So I like the idea of including a consumer and then the CAC member. I just don't know if we have any members of our current CAC that fit that description. We have experience with behavioral health system. We can invite, ask.
And I know the national advocates for mentally ill are usually very willing to sit in and speak from a client perspective or a family perspective of what's being proposed. I don't know who their local rep is, but I know they have one.
Carmen, I think when it comes to public health, I would identify emerging topics and initiatives supported by data. I don't know if anything on it, but I think it's going to be important to bring in some of our regional epidemiologists to really be able to look at data. When we say fentanyl, opioid, we've got some data.
The only other thought I would add to the conversation is, obviously this is all levels of behavioral health for all type of demographics. The folks on here, Shannon and Janice and others, have worked extensively with students and children. I wonder whether during sections that relate to 0 to 21, if someone from the education community might be helpful.
Okay, I can take those recommendations back to the group and hopefully we'll finalize the process by next month. Get started.
Thank you. Thank you.
Next on the agenda,
That's pretty much it. Was there anything else you wanted to insert? I think you wanted to insert.
Yes.
Please, okay.
we had an oversight on the agenda. Last month, the board asked the governance committee to have a discussion about the role of the council in emerging issues, particularly the Medicare Advantage issue. And at this point, there were a couple of other issues too that the council considered. The first one was the Medicare Advantage issue. The role at this point is, that the governance committee has discussed and is supportive of, is that when an emerging issue comes up, regardless of what the topic is, that having the executive committee meet and discuss it, talk about what their action is, and if they feel that something more is needed, that the board be advised at the next regular meeting of the topic, so that the board as a whole can be involved. And if it's something that is so urgent or catastrophic that it needs action before the next board meeting, we can always do a special meeting in the middle. In the Medicare Advantage piece, I think the board or the governance committee was comfortable with the council being an impartial, unbiased source of information for clients that may or may not be affected by this issue. Beyond that, I think that's pretty much our primary role in this situation, would be to be a resource. The second topic that we talked about is we've been going through the data for our annual board self-evaluation. Out of that, we haven't had the minutes from the retreat yet, so we don't have the full bank of information. But we did talk about one comment that came up periodically during the board retreat, and that was that sometimes this board feels challenged that we're not diving into some of the more uncomfortable discussions that we should be diving into. And so the executive committee wanted to share a thought that perhaps on a quarterly basis, we pick one of those topics, which gives us a month or two to determine what information does the board need before the discussion, so that we come into a discussion fully prepared, and what would those discussion topics be. So I'm gonna ask you after the meeting today, if you've got a burning issue or an issue you think that the board should be talking about that we're not, if you could send that list to me on governance or Tammy or Carmen, then we can make a list and put it into a schedule and come back with a full big proposal on that one piece. And then at our next month's meeting, we'll review what the full, when we get the minutes from the retreat, combine that with this board self-survey, and come up with a set of recommendations on what education is needed for the board. Did I catch everything? Yeah, I know you're on governance committee. Great. Any thoughts for governance committee or feedback or questions? No? Done. Okay, I'm sorry?
Can I just do a little announcement, cause I think this news was reflected in Tricia's report, but just in terms of organizational changes in the broader marketplace that impact one or more players here, we always kind of give somebody an opportunity to say, here's what's going on. So can I take 90 seconds and give you a quick update as to the OHSU legacy transaction, which then has an organizational affiliation change for Pacific Source. Some of you I've spoken to individually, But, so Tricia, thanks for putting that in your CCO director report. If you haven't heard that news, in the market, it was the second week of last month. It's the week I was on vacation and missed the meeting. But yeah, so Legacy and OHSU, two big health systems in Portland, are affiliating. The surviving entity will be OHSU. Legacy assets after that is approved, and the approval can take anywhere from 9 to 18 months, depending on how the different regulatory bodies look at that. And there are multiple, including this newer process, right, that OHA does to approve merger and acquisition transactions in the state of Oregon. So that'll be a part of this process too. Most of you probably recall that Pacific Source organizationally has two parent companies. One is, and they each have 50% membership in Pacific Source. We call it membership because we're not for profit. So it's not shares or ownership, it's membership. Legacy Health is one of those, and the other one is an organization called Pacific Health Associates, which is an organization that we lifted up to be our 50% corporate affiliate when we did that Legacy transaction, which was in 2017, so coming up on 6 years ago. As a result of the OHSU Legacy transaction, a couple things that, and there's a whole bunch there that I won't speak about because we're not party to that transaction. But the part of it that impacts Pacific Source in terms of our corporate affiliation status or membership goes like this, simply stated. So when that transaction completes and is live, Legacy's assets, as is typical for these kinds of things, go into a foundation. And there will be an estimated $450 million of sort of excess cash, net assets from Legacy that go into a foundation. That'll be a not-for-profit foundation for health improvement. It hasn't been chartered yet or bylaw. We don't know who's going to serve on that board yet. Legacy also, and that's pretty typical, right? You see the Foundation for Health Improvement in the Pacific Northwest, the Jeff Hetherington Foundation, which was an outgrowth of the family care change in status. So it's pretty typical for that to happen. So this is in keeping with that. However, the interesting part for us, and the reason why I think the foundation is important, is because Legacy's corporate membership, their 50% ownership of Pacific Source, will not transfer to OHSU. It will also go into that same foundation. So we will become, and that's actually it's not quite exactly the same, but it mirrors the other 50% parent that we already have. So we have this really unique ownership structure. When this transaction goes through, we move from being what you might argue was partially provider affiliated, kind of vertically integrated with a hospital health delivery system, who had certain limitations because it was a 50% ownership, but they had the composition of our board, it was Legacy appointed. So 6 members of our board have been for the last 6 years appointed by Legacy Health. All of that will transfer to that foundation. So our ultimate corporate affiliation when this is all done we'll still have 2 parent companies. They will each be 501c3 foundation or foundation-like entities, and we think that's really exciting. The opportunity to be independent in that way, we don't think it materially changes the way we've been working with Legacy. For those of you who know how we operate in the Portland market, we didn't move in the direction of being exclusive to Legacy, nor did Legacy move in the direction of being exclusive to Pacific Source. We built some products with them. We've done some things around population health, shared investments. Those things we will try to continue those things with the surviving entity OHSU, and we've got a great relationship with OHSU. Our members go to Portland for care there. Our Portland members seek care there. They're in our networks. So that was probably more than 90 seconds, but I just wanted to sort of, if you have any questions about it, feel free to reach out. Every transaction is complex, and this one has kind of this twofer, where what's going on with Legacy and OHSU, and how's that gonna play? But downstream from that, what's going on with Pacific Source and how does that play? So Yes.
I mean, general question, is that for all lines of business then, not just the CCO?
Yeah, it's for
Okay.
Pacific Source, we have sub-entities, as you know, our PCS, the CCO entity is a sub of Pacific Source Health Plans. It's the parent entity, and therefore everything under that. Yeah. So we're excited about it. There is potential, there are things to be worked out and to try to influence, but it's not lost on us that if we could align that foundation's interests in terms of what they invest in around community health and access and other things, behavioral health perhaps, that would they align those investments with that of a community health plan such that there's a sort of an investment arm and an execution arm that could work hand in hand. So ways that we would like to possibly influence that to strengthen what we do across various markets, including this one, but details yet to be determined. So there's a fairly detailed letter of intent. The letter of intent between Legacy and OHSU was publicly released along with the press releases. So if you're one of those people that as you read articles, you click on everything in the article, the LOI was actually it's in some of those articles. And it's an interesting read for more detail if you want to go back and look at that. If you would like me to send it to you, just reach out. That's public information. And it describes a little bit of the foundation, the initiation of the foundation and the details that I just mentioned about the transfer of the Pacific Source asset to that foundation in that LOI, about on page 5.
How many?
Only 8 or 7, yeah. So anyway, hopefully that's helpful. That's just, I know as is customary here, if we have things that are affecting us organizationally, merger, acquisition, joint venture activity, I just wanted to, in that same vein as Justin did however many months ago with Walgreens and Village MD, sort of like, here's what's going on. Feel free to reach out if you have questions. I can share what I know.
You can post it on our website too as news.
Perfect. Thanks for the minute. Thanks for the 4 minutes.
No problem. Any other announcements for the good of the order, anywhere? If none, consider the meeting adjourned.
Thank you.